things started with Lilia giving some fun lab updates, and then we'll take it from there.
Okay, sounds good. Okay, so getting started. We have first our lab announcements. We have Winter Wishes that is kicking off, and Michelle is joining us to talk a little bit more about our fundraiser for OB Motivate.
Yes, thanks, Lilia, for the introduction. Hi, everyone. It's Michelle. I am the OB Motivate Clinical Coordinator, and we are super excited that we have started the Winter Wishes initiative for this winter. We have already started purchasing some items already, so we're really excited about that. And we plan to start giving those items out in the next few weeks. Again, this is to support our patients who are on their recovery journey, and we're purchasing our items from Little Nomad this year as a sponsor. And then we have the different tiers for giving. And we have the $10 that will support the wipes and diapers, and then we have the $50 for a gift for a child and spa products, and then $25 for a tour for a child or other spa products. And although these are our tiers for what we'll be purchasing, you are free to give at any amount that you would like to. And thank you, Dr. Martin, for adding that link into the chat. I was just about to do that. So perfect timing. And this flyer was sent out to the masses, and I saw that Lilia sent it out to her listserv as well. But if anyone else needs it specifically, please don't hesitate to reach out to me. I can put that in the chat as well, so you can send it out to your various work groups so we can continue to support our Winter Wishes Fund. Thanks, everyone, and thanks again, Lilia.
Thank you, Michelle. Okay, and moving forward with our announcements, we had 2 ASAM submissions this past cycle. Hannah and Susie and Michelle and Dr. Martin submitted an abstract, and then our Castle students also submitted an abstract. So fingers crossed. Okay, and we currently have 3 manuscripts in review. We have AB's paper, Brenna's paper, and Shavania's paper. And we actually had quite a few manuscript acceptances this past month. So Dr. Martin had 3 papers accepted, and then AB had a paper accepted. And here's our social media plug. If you are interested, you can give us a follow on Twitter. We also have a YouTube channel if you just want more about our research. We upload all of our meetings on here, so if you want to catch up on past research teachings. And now going into the active studies we have going on. So with Better, we have completed recruitment if you missed last month's meeting, and we're currently finishing follow-ups. And so Project Better provides a theoretical grounded assessment of the feasibility and acceptability of a new technology delivered education intervention for pregnant and parenting people receiving medication for opioid use disorder. And Annabeth is the graduate RA that is in charge of this project. And then for Project SORT, also super exciting, recruitment is complete. Chart reviews are ongoing. SORT is a study that investigates the relationship between sleep and opioid use disorder recovery. And Michelle is the graduate research assistant on this project. Okay, and then the registry is an ongoing study that tracks clinical outcomes of our pregnant and parenting patients who seek addiction treatment with OB Motivate Clinic. We currently have 133 participants enrolled, and AB and I co-lead this project. And then for postpartum recovery, recruitment is complete, follow-ups are complete, all chart reviews are completed, and postpartum recovery compares biopsychosocial factors such as pain, mood, impulsivity, and maternal infant attachment compared during the 3rd trimester of pregnancy and within 6 weeks postpartum between women with opioid use disorder. And AB leads this project. And then we have Project Castle, which the intervention is currently being built for this project. We're super excited about this project coming off the ground. It's a computerized intervention that educates medical professionals and pre-medical professionals on substance use disorder stigma. And I lead this project. And our next lab meeting will be on November 21st. And we'll be sending out the invite within the next 2 weeks once everybody finalizes their plans for Thanksgiving. And if you are interested in teaching at one of our lab meetings, it's a great experience. Please reach out and let us know. Or if you have any updates or questions, feel free to shoot me an email. That's all from the updates.
Awesome. Thank you, Lilia. We've had a lot of things happening in the lab, so it's fun to be able to share them in this forum. In addition to everything she said, this upcoming weekend, we talked about it last lab meeting, but we have multiple people who are presenting at the Virginia ASAM, so the Virginia chapter of the American Society of Addiction Medicine this weekend. So we're excited to cheer on everyone from the lab who will be representing us. I will be at a different addiction conference. Somehow they're at the same time in Washington, D.C. with the OB Motivate team, and we'll be presenting some research there too. So ironically, this weekend, the Ivy Lab will be in 2 different places presenting their research. So we're really excited about that opportunity. And thank you to Michelle for talking about Winter Wishes. The OB Motivate team, we do this fundraiser every year, and everyone who gives to it just says how thankful they are for this opportunity. And we try to catch people before the holidays when people tend to get a little bit overrun with things that needing donations. And also due to the way that we do a hybrid telehealth and in-person visits in the OB Motivate clinic, we give out the gifts over kind of a 3-month period starting theoretically next week. So the beginning of November. So if you can just help us out by sharing that link and that opportunity within your circles on social media or friends or family or colleagues, we just need all the help we can get from an internal way to spread that opportunity. So thank you for everyone on the lab side for helping with that. Awesome. Well, I'm not going to belabor any more points. I'm just going to go ahead and introduce Ellen, who has volunteered to be able to, at this meeting, talk about some of her research that she is also presenting at the conferences, one of the conferences that I just mentioned. So I'm going to turn over her. Ellen, if you can just start by just introducing yourself, kind of where you are and all the things, and then we'll lead it over to you. And then we will love any discussion at the end or any feedback that anyone has on the call. Ellen is actively working on devising the abstract and the paper and the analysis plan for this, and also the next steps for future studies all at the same time. So we love being able to have feedback while that's going on. So I'll hand it over to you, Ellen.
Thank you. I'm Ellen. For those of you guys who don't know, I'm an M2 at VCU. I'm definitely interested in women's health and addiction medicine. So I was like, this is like a perfect place to do research. Anyways, so my research here, let me share my screen. All right. So my research looked at the labor and delivery pain expectations and experiences of pregnant people receiving buprenorphine. And so a little introduction. So pain is a multidimensional experience, and it's influenced by a lot of factors like one's environment, one's psychological state, social determinants of health, one's previous life experiences, etc. And people with opioid use disorder tend to have more complex pain experiences as a result of post-traumatic pain, fear of opioids, opioid-induced hyperalgesia, which is like alterations in the psychophysiological pathways that sensitize them to certain painful stimuli, as well as limited effectiveness of opioids in the presence of systemic buprenorphine. And so that kind of predisposes them to be at a higher risk for poorly controlled postpartum pain compared to people who don't have opioid use disorder. And that can lead to really negative outcomes like maladaptive responses, progression to chronic pain, and return to use. And so a lot of the literature that I looked at tends to focus on pain outcomes in the context of like total opioid consumption, prescribing behavior, or like pain intensity on a scale of like 0 to 10, as we probably are familiar with. And there's not as much research on how pain affects measures of function. In addition, patients with opioid use disorder report a lot of anxiety about the pain associated with labor and delivery, as well as concerns about the use of opioids during like labor and return to use during the postpartum recovery. So my study objective was to describe the pre-birth pain expectations and postpartum experiences of labor and delivery pain in an opioid use treatment sample. And to do this, we did an a priori secondary analysis of a longitudinal cohort of postpartum people with opioid use disorder receiving buprenorphine. So it was the postpartum recovery study. And the sample size was 26. All the participants were recruited during their third trimester, and they completed surveys that were adapted from the brief pain inventory, where they had to rate their pain intensity and pain interference with certain activities on a scale of 0 to 10. They completed these surveys at baseline and then 2 days after delivery and then 2 weeks follow-up. There were also additional questions asking about pain management satisfaction and also rating that on a scale of 0 to 10. And then L&D outcomes like the type of anesthesia, delivery mode, et cetera, were abstracted from the medical record. And the specific variables that we chose to focus on were the labor and delivery pain intensity, pain interference with daily life activities like walking, sleep, mood, feeding and bonding with the baby, and then pain relief and satisfaction with pain management regimen. So these are my results. And this first table kind of describes the baseline characteristics of the sample that we studied. And so our study sample was predominantly white. I think also notable is that about 40% of the participants did report like a baseline chronic pain that averaged around like 3.3 on a scale of 0 to 10, with 10 being the worst. And also a majority of the study also reported having some sort of mental illness, which can also affect one's pain experience. The second table describes the obstetric labor and delivery outcomes. Most of the sample or the participants had a vaginal delivery, and then a majority of them chose to have some sort of anesthesia during or before labor, with most of them choosing to have an epidural. And then this third table kind of describes the labor and delivery pain variables that we looked at through the surveys. So the different variables that were the pain intensity. So the pain, people rated it at its worst, its least, and then the average, how much pain relief they felt they were getting from the treatments and medications provided for them, as well as their rating of like how satisfied they were with the labor and delivery pain relief. And so the kind of key takeaway from this table is that people tended to rate their pain pretty high, like at its worst. But they also had a realistic expectation since their expected pain was rated similarly to their 2-day and 2-week follow-up. Similarly, the pain relief that they expected from their treatments and medications were rated similarly to their actual experience at their 2-day and 2-week follow-up. This third table, or this figure, kind of describes the pain interference with the activities of sleepwalking, mood, relationships with others, enjoyment of life, and then bonding and feeding the baby. And so the first line, the blue line, kind of shows how people rated their expectation of how much pain would interfere with that specific activity. And then the yellow and pink lines kind of show how they rated their actual experience with how pain interfered with those activities. And so what's notable here is that people tended to rate sleep as having the greatest interference. That was their expectation. But then when we looked at the surveys at 2-day and 2-week follow-up, people rated walking as having the greatest interference at 2-day, and then pain interfering with their mood the most at 2-week. In addition, we found that the postpartum pain did not really interfere that much with how people bonded with and fed their baby, so their postpartum responsibilities. And so as for the discussion, I feel like further qualitative research on how pain interferes with the daily activities for pregnant people with opioid use disorder on buprenorphine is necessary to better prepare patients for pregnancy. I think self-reporting and having better descriptors for pain can help us develop interventions that are more specific and effective to address those pains, because pain scales of like 0 to 10 can be very subjective and inconsistent throughout like a sample. And it also doesn't give us a good indicator of how the pain is in fact affecting their life. So like if they're not able to do an activity completely because of a pain, or if they're able to do the pain but with discomfort or with assistance, I think those kinds of descriptions can help clinicians better like interact and treat their patients versus having like a scale of 0 to 10. So yeah. Any questions?
Awesome job, Ellen. That was great. We've been wanting to look at this data for a while, so it was really exciting to see it. Can you pull up the figure? I feel like this might be where people might have comments the most, so it might be good just to keep this one up. I'll kind of start things off. I was just curious, kind of in the line of the discussion that you just brought up, like, gosh, what would be the next steps from an intervention standpoint, and then take a step back from that. What should we then ask about in the qualitative work, right? Because I know that's what you're thinking about too, trying to design a qualitative interview guide for another study. And so I was curious, thinking about that, what areas from this figure did you initially have the reaction of like, oh, that's interesting, or I didn't expect that, or I wonder why that's happening. We should ask patients more about that. So I was curious if which of these results kind of caught your eye when you were initially putting these things together.
I think my initial assessment was that the baseline expectations in general were higher than the actual experiences across for all the activities, which like made me wonder like what patients were expecting, I guess, with pregnancy. And I think that was kind of where I started. And then just like looking further like at how like I think for me at least, I hear a lot anecdotally how like people don't get a lot of sleep when they have babies. And so like I could see how that like kind of creates a narrative where like a lot of people come in with that assumption and like expectation when they have kids. So I think just like understanding like where people have the expectations can be helpful in like, oh, like what kind of interventions or like what kind of counseling could we do to like better help prepare patients like when they come in with their concerns.
No, that's a good point. I'm kind of just thinking a lot about this. So I think there's a lot of opportunities, but I'll open it up. Does anyone else have any questions or feedback or just points of discussion that we should maybe think about as we're thinking about next steps? Leah, I'll let you go.
Oh, okay. Well, I'll introduce myself as well. Hi, everyone. I am a prospective MD PhD applicant for VCU. So I just came here to learn more about the lab. I did have a question about the buprenorphine doses of your participants. Like, was it all the same, or like, how did you determine the dose? And if they were on different doses, were there any dose dependent effects?
So they were on different doses, and in my table I only have the mean buprenorphine dose, but like everyone was either on Suboxone or just the buprenorphine or the buprenorphine naloxone. So in terms of like how the dose dependent is not something that we have explored yet in this specific study. It was more of like a describe like what was kind of what we observed, I guess, from the surveys.
That makes sense. Thank you.
Yeah, that's a good point. We can make sure to include that in the write-up, that this was a very unique sample, because these people all were like engaged in treatment and they were in our clinic and they were on buprenorphine. I don't remember the average of how long they've been on it. But this was a pretty selective group, if that makes sense, of people who have been on medication for a little bit of time at least and doing relatively well in their recovery. What other questions or points of interest did anyone else find?
I think something else that the thought just occurred to me today, when I was like looking at my poster again, was kind of like why like people's pain expectations were similar, like they were realistic in a sense. So something that like me and AB were gonna look at was kind of like how many pregnancies like the participants had, because I know that like previous life experiences can play a role in setting expectations. Like if you've had a baby before, then you kind of know what to expect in terms of pain, versus like someone who's never, this is their first pregnancy, and that might kind of affect like how people expect to feel pain during pregnancy or during delivery, labor and delivery, versus like how they actually experience it.
I just ran it for you, Ellen, and sent it in the chat, and it was like 75% of the participants had had a previous delivery. And so I think you're right in your hypothesis that that's probably because people have been through it before, and so they had a realistic expectation of what the pain would be like. So yeah, good thought.
Gus, I see your hand up.
Hey, Ellen, great presentation. You might have mentioned this and I just missed it. I apologize if so. But I was curious, were you able to observe or collect the method of delivery, whether it was a vaginal delivery, a C-section? That might be something probably highly related to the postpartum pain experience. That would be
for sure.
you do have it on there.
So yeah, majority of them did have vaginal, which like from my previous literature review, I think it's also interesting how like participants who or people who choose or do a vaginal delivery and then versus a cesarean delivery have like different pain experiences in terms of like sharp, like stabbing pain versus like achy, dull pain. So I think that's also like a realm that would be really interesting to look at, because there are different interventions for different types of pain as well.
Yeah, certainly. One thing you could do, just we don't have a lot of power here, obviously, with the sample size, but just stratify your analyses based on method of delivery and recreating that chart. Might be kind of interesting to see if there's different trends in the subgroups as compared to when you're kind of looking at everyone balled up together. So just something to think about, but really, really cool work. Thanks for sharing.
For sure. Thanks.
Hi, Ellen. I'm Megan. Student. You guys hear me?
Sorry, you like broke up a little bit.
That's okay. I'm a fourth year medical student. I was surprised that it seemed like the mood prediction was pretty spot on. So I'm curious if you found in your individual data that patients were really good at predicting their own mood impact. Because I think from a provider standpoint, if we found that patients were really good at predicting that, I would want to know if someone felt like they were going to have a hard time. And maybe you could put a few more resources into those patients.
For sure. I think an interesting like factor, I guess, that I thought of like that would factor into this was kind of like how a lot of the patients also experience like some sort of like psychological or mood disorder. So like a majority of the patients had anxiety or depression or PTSD. And so I think just like having prior experience of like knowing your mental health status, etc., might make you like better at predicting like how you're going to like experience certain things in the future, or like in that way. So that was just like one thing that I thought of when I saw like the mood data.
I was just curious, Ellen. I hadn't thought about this until right now, but looking at the absolute numbers of expectations and then what people actually stated, it seems to me, unless I'm getting it, unless I saw it wrong, that when we use the word pain, like on your slide before, the numbers were, yeah, like mean pain in its worst, like that 8 just was the same across the board. That is a lot higher than, and it's the same 0, 0 or 1 to 10 scale, but that we used, versus these function questions are kind of, the highest is at 5.5. So I was just thinking too, like, gosh, when you're using the word pain, maybe that has something to do with that kind of descriptive that we're seeing difference between these function questions and then asking people about their pain. And I think that seems like that goes along with what you had pointed out earlier about making sure that we are trying to figure out how we can do a better job of assessing, not just assessing people's pain, but assessing their expectations and things like that, not just asking on like a 0 to 10 scale. So I was just curious if you had thought about that, the difference in the questions that we used on the slide before versus the questions we used for this. And if you thought about anything related to that we should focus on in the qualitative follow-up.
For sure. I think like self-reporting is like a good avenue, because I think like you were saying, like people can interpret the question like in a way, like I don't know if pain interference means like you're like that's your pain while you're completing the activity, or like that's the degree to which pain is like withholding you from doing that activity. So like I wouldn't be able to know that on just like a quantitative scale, versus like someone explaining to me like this is how my postpartum pain is affecting this like realm of my life, I guess. And so I think that's definitely a good avenue to look down.
Yeah, I feel like it's all tied into the opioid crisis too, but we're really good at asking people about their pain, but I feel like as patients, people are not as used to being asked about their pain function, the function changes due to their pain. So yeah, I think you bring up a good point. Just these patients have been asked probably the same pain question a million times, right? When they've been in the hospital for surgery or whatever else, but there might be a little bit of not fatigue, but difference in, what they're used to being asked from a function versus a quantitative pain perspective.
For sure.
I think that's interesting because it's kind of been that trend across all the like secondary analyses that we've done with postpartum recovery, that these participants are really like dealing with a lot, whether it's physical pain, like different psychiatric comorbidities, child welfare, like all the different stressful things that they have going on, but they are able to function at a high level, given everything that they're dealing with. So I think it's just another way that's highlighting kind of the resiliency and trying to better understand how they are able to function so well and what supports them to do that.
Any other feedback or areas of interest that people found with the results? This is really helpful, by the way, all the discussion that we've been having as Ellen and the rest of us think about next steps with this data. Okay, well, if not, then we'll end early. Ellen, this was really great. Thank you so much. We should have a meeting in the nearest future and talk about all of this and figure out what we're going to do, because I feel like there's so many opportunities for all the next steps. But congratulations on presenting your poster this weekend, along with all of our other Ivy Lab trainees that are going this weekend. You guys, I already know are going to represent us really well. Great.
Thank you. Thank you for having me.
Yes, thank you everyone for coming.